I really want to welcome our next panel up, Unburdening Patients and Doctors. What should the government do? Yeah, you can clap.
Do you want to sit in any order?
Doesn't matter. So we are not focused on DOGE. We're focused on what you all are seeing in your businesses, and maybe one of the things that CHC has been working on really is trying to collect stories from the field about what is causing pain, what makes sense, what doesn't make sense, and how can we kind of bring that to the attention of leaders who are interested in eliminating some of that pain. And so, David, I wanted to start with you. You are a member of our advisory board. You have been for a long time. You're a practicing doc. You have an impressive and colorful career working with law enforcement, solving murders, being on flight surgeon teams, but most recently as a member of Team Health, practicing doc, managing a lot of folks out in Ohio in Max Miller's district. We met yesterday with Senator Marino's office. And why don't you tell us a little bit, with your dust on your boots in the medical field, what are you seeing, and what are some of the pain points that you want to highlight?
Sure. Yes. I guess first I want to make sure nobody has any apples. So just to kind of stay with that theme. Otherwise,
he is a doctor.
I might need to start ducking. It's very eye-opening as you start going through this. You start thinking of all of the opportunities that are really out there. And I think that when you realize where the pain points start, I sent Joel a list of probably about 90 items. So when he asked this question, I'm like, where do I even begin? And you have so many challenges facing the healthcare industry right now, and a big portion of that is the regulation burden that we have to go through. And some of the simple examples to kind of highlight that I think a lot of people don't realize. In my role as currently I'm CMO at a hospital in Northwestern Ohio, as well as regional medical director with Team Health. So we manage a lot of different contracts. I've got contracts in Ohio. I've had them in Pennsylvania, New York, currently in Indiana as well. And you start seeing across states, there's a lot of challenges facing. One of them is getting providers credentialed. And so as a physician, if I'm trying to have one provider move from one place to another, during COVID, they did away with all of these regulations that you had to go through. But currently, right now, everything kind of got reinstituted again, and you have to get a state license at each state that you practice in. When they go through that process, you have to verify you went to med school, you did your residency, you do a background check, you go to another state, they do that same verification that you went to med school, that you went to residency, that you've completed your background check. So everything gets redundant and repeated, and it delays and takes time. Some states it can take upwards of 6 to 12 months to get somebody licensed to be able to practice. Well, how does that affect the cost? Because currently, if I'm short-staffed in a facility and having to pay physicians extra and bonuses to be able to cover these shifts because we can't get providers into that state to work, you're just creating a significant cost that offers no value to any patient. Then you also have the burden that you have people doing that job and doing those background checks, which is also very labor-intensive and costly. Once you get your state license, you also have to get a DEA license for each state, going through the same process. And once you've completed all of that, now I can apply for medical staff privileges at the hospital. And lo and behold, they do the same thing. They go back and verify that I went to med school, that I went to residency. They do a background check on me. And there's companies and layers that offer the service to do all of this. So every step along the way, the organization, the facility, is paying money to have that done. And just delaying the process. That's just one of the most glaring things that you look at and you say, where is there opportunity to just, trim some of that and make that simpler? Like I said, I could go on about the other 89.
Well, no, the interesting thing is that, we have a natural experiment here, right? Like, we had the rules in place. We went through COVID where we suspended the rules. We saw how it worked. Didn't seem like people got access to care. There wasn't harm there, and then the rules snap back into place, and now the costs come back. Mm-hmm. So this is a logical one where we say we went through an experiment and we learned, and now we can revise and reform.
And it's not saying there shouldn't be some form of confirmation and a process to do it, but it doesn't need to be 50 different ways to do the same thing and then however many hospitals are in the country. Each hospital has its own process too.
You know what I think about? I think about every time I try and log into my Microsoft account, when they kick me out and they say you have to log in again, it's like there ought to be a technology solution for this, right?
Yeah.
Like there ought to be a centralized database where you can check credentialing, licensing, residency across all 50 states, right? Like it doesn't seem that hard. There might be some power issues or money issues that come into play with state licensing and things like that, but a solvable problem.
Right. And there is effort being done, and some companies are looking at trying to solve that problem, but you're right, they hit roadblocks along the way.
Yeah. So Megan, Vice President of Payer and Regulatory Solutions for Solventum, Health Information Systems. Mm-hmm. Yeah, there we go.
Formerly 3M. Some people
formerly
know who that I'm
3M,
talking about.
if you ever use Scotch tape, there you go.
Mm-hmm.
But Megan and I started working together back when she worked for Jim Ramstad, a wonderful member of the Ways and Means Committee. And she's been in her current role for a long time. There's a lot people don't know about what Solventum does in terms of coding and quality in the Medicaid program and the Medicare program, and how hospitals get paid. But you've done a lot of work in Medicaid quality and making things work easier and better. What are you seeing out there? What are your thoughts on this?
Well, if I had to look at what could we do to make it a little bit easier for the system, I'm going to focus on, because again, there's probably 90 things we could each put out there. I didn't do a whole list, though. I wish I had. I would look at value and quality reporting that's out there. Now, Joel, 20 plus years ago, when we were young kids and we were doing this up on the Hill, we talked about moving from volume to value. And it was the right thing to do. It was important to change the incentive from, incentivizing additional hospital visits and lengths of stay to, focusing on better patient care and reducing costs. And, again, good intentions, but when you're at an inflection point, which I think we are today, like we've been hearing a lot today, you have to step back and say, are we moving the needle? Now, I'm not a total Debbie Downer. I'm not going to say everything's bad. I think that we have made some improvements. Certainly when you look at the never events list, and if you're making sure you're preventing a patient from having something sewn up inside of them or a fall in a facility, that's good. That's good for the patient. It reduces the cost. But if you look at it in sum total and all the programs that are running out there, are we reducing costs? Are the patients healthier? And are we really getting a return on an investment from all these value programs that we're running? And I have numbers because I don't want to misspeak them, but there was a JAMA study in 2023 that was reported out in June 2023, and it looked at the annual costs, and this is just for acute care hospitals, for running these quality programs. And they said there's 162 unique measures, requires over 100,000 person hours to run them, costs over $5 million for that personnel, plus an additional $6 million in vendor administrator fees. Now, Joel, that's just acute care hospital setting. That's not other provider offices, other settings. We're spending a lot of time and effort. And if I look at, there was a stat article in 2022 that Sullivan, Malinow, and Tillow said, listen, we're spending tens of billions of dollars on these value programs, and they're done very little to improve Americans' health. And we know the providers are unhappy, right? They're probably the chief vocal, people who raise and say, look, you're taking a lot of my time. It's a burden to do all this stuff. So, I'm going to say, what can we do? I'm not going to say stop doing it. It's the right thing to do. But what did Einstein say? Something about if you keep doing the same thing,
over and over.
And expect a different outcome. We've got to have change. And if you look at the first Trump administration, when Seema Verma came in, CMS, she said, I don't like all these process measures. I'm going to do something. And I think she made a real effort. And maybe there were some things that were done, but it was a small dent because they're still there. They continue to proliferate. And we really need to look at what can we do? Because, if you look at, you'll know better than this, so you can correct me when I say something wrong. If you look at aspirin at arrival, that's a good measure. There's something valuable in these measures that are out there, and they're good for an ER to follow. The pain assessment and follow-up measure to make sure that we check up on patients. Did they see their specialists? Should they come back to our office? These are all good things, but they are process measures. And they are directing the provision of care. They're requiring a new system to set up how you report on all this. They're inconsistent, they're unclear, they're debatable about how you score them and weight them when you're impacting payment. And they are proxies. They are proxies for patient outcomes. They are not real outcomes. They don't tell me how healthy is the patient. Have I reduced costs? So if we try and focus there, we can go back to the initial question, which was, are we reducing these expensive and traumatic situations for patients? Are we reducing complications? And that's both inpatient and in the ever-growing ambulatory space. Are we reducing potentially avoidable hospital admissions and readmissions? Are we reducing unnecessary ER visits? Because, if we can do those 4 things, that's good for the patient. Nobody wants to be in the ER, especially on a Friday night, right? How many people have had their kid with an ear infection on Friday night? It's the worst place to go.
Yeah, it is.
You don't want a hospital admission. I mean, these are all good things for the patient to avoid if you can. It saves money. And it does it in a way of saving money by not cutting physician payment, but don't want to do that, by not denying care, but by bending the cost curve because you're just avoiding a costly event.
And there's I know in the past we've worked on legislation around hospital readmissions in particular and the quality measures. You see that maybe getting some steam as we think about like these burdens that we're putting on hospitals and the docs who work in them?
Definitely, there's a number of states that are starting to do this. Texas has a program. They have 4 different programs within their Medicaid: STAR, STAR Plus, STAR Kids, and STAR Health. They've been doing potentially avoidable admissions, ED visits. They've seen double-digit reductions across all those. I think even with STAR Health, it's been a 50% reduction in hospital admissions. Wow. Readmissions are down 12%. If you look at Florida, they've been doing similar programs, and these numbers are from 2019 through 2023. They similarly have had over 10% reductions in admissions and ED visits, and I think over 50% in readmissions. So you can kind of go across these states, and what they're doing is saying, and they're not getting rid of all the process measures, but they're reducing some of them and adding in the focus, really, especially the financial programs that they have, their quality programs, or just reporting programs, focused on outcomes. And they're saying, look, we're going to make sure that if there's a financial incentive, it's clear and understand how it's done. It's going to be comprehensive, and it's outcomes-based. So if we go back to kind of our example, if I'm looking at that heart attack patient coming in, like Florida, they're going to say, I'm going to look at the outcomes for that. What's the mortality rate? Instead of the aspirin on admission. So that's kind of the approach that we're seeing hospitals, and they're saving Medicaids, and they're saving real dollars.
We need to figure out how to elevate those best practices. But it reminds, like what you're saying on the hospital side, Lisa Harrison, an unbelievable leader in the private sector for efficiency and logistics and distribution and care. Is the Senior Vice President and President of Specialty Distribution and Solutions for Cencora. Lisa, you do a lot of work with physicians. Mm-hmm. So like taking what Megan just talked about, like what are you seeing in the physician space with some of these quality issues with some of those specialty practices?
Sure. The specialty physicians that we work with, would call out that the Medicare quality program, MIPS, in general, is not really meeting the mark. A lot of administrative burden in order to document on quality measures that unfortunately don't do a lot to determine great care from poor care. And that's time that physicians could be spending with patients instead of documenting quality measures. Of course, all of the cost associated with that as well. Joel, there's also a bigger issue of just physician reimbursement and physician pay. One of the only provider groups that does not get an annual update for inflation, the AMA would actually tell you that physicians are making 29% less today than they did in 2001 when you adjust for inflation. We want great quality care, and that requires investments by providers into their practices, into the processes, into the resources in their practices to deliver that. And unfortunately, year after year, we're back here talking about another cut to physician reimbursement. And in that environment, it really is tough for a physician who owns a practice to make a decision to make investments into, things that would perpetuate value-based care. And so I think that, really is one of the top areas that we unfortunately continue to be focused on year after year.
Yeah, coming back and asking Congress to fix a problem, I remember that. But so one of those areas of value-based care, you do a lot in the cancer space.
Sure.
The enhancing oncology model, I think we saw the original model, and then the new model came out,
Right.
and kind of participation went way down.
Right.
What are you seeing there with some of these value-based care models? Is that kind of an area where we can do a better job?
Absolutely. It's another example. We had several hundred practices participating in OCM, which was the original oncology care model. And when we transitioned to EOM, we asked physicians, providers to do more with even less. We saw MEOS payments go from $160 per patient per month to $70, while also asking those providers to make investments in their practices and in their resources to support patients. Additionally, the number of cancer diagnoses was drastically reduced to 7. So also then requiring a practice to bifurcate how they care for patients, which creates additional operational burdens. So, not surprising, we have 40 participants in the EOM. I think, there's, as always, well-intentioned, but just not really feasible for practices to be able to participate and provide the care that they're being asked to provide at, with the reimbursement that they're being given.
Because we've talked a little bit about this, I want you to maybe highlight the area in cancer care specifically where doctors are trying to get cancer patients medicine they need, and there's a regulatory barrier right now. Can you talk about that?
Sure. So that's what we refer to as the Stark issue. So Stark, which of course is the physician self-referral law. One of the exceptions there is that a physician can refer for dispensing of a treatment to their patient. And physicians have done that in due course, especially with a growing number of treatments that are oral therapies. In September of 21, we saw a CMS FAQ that essentially said it is a violation of Stark if you are dispensing that treatment and either mailing it to the patient, providing it via courier, or even to a patient's caregiver or family member. And so a patient, in this case, oncology patient, would have to physically come into the practice to receive their refill of their prescription. As you can imagine, that is a significant burden on the patient or the caregiver who has to take off of work to bring them in to pick that prescription up. And again, hidden in a CMS FAQ 20-page document, the last page. During COVID, we saw, because of the public health emergency, we did see a reprieve during that time of this. So much like David was referring to, we've seen how this can work, but with the public health emergency expiring, it's once again, a burden on patients and their families just to get their necessary oncology cancer treatment.
Yeah, and these are not people who are like, I want you to send my flu medicine home, right?
No.
Like, these are sick people. You don't want them to come into an office.
Right.
You want to get them the medicine to make sure they're adherent.
Right.
That is, yeah. That is, I
Absolutely.
would put that one on the list too.
That's right, right?
Yeah,
I was
David.
just saying, it kind of highlights when you think about that, because there's a lot of scenarios where you can talk about that, where regulations and the guidelines don't put the patients first. And it puts everything else, in that process, instead of thinking what is truly best for the patient.
Right.
And trying to break that down.
Yeah.
Right.
Yeah. And I mentioned at the beginning that CHC is collecting a list of ideas, and we're working with our partners to kind of get those ideas together and elevate those with the decision makers. And I would encourage everyone here to do the same thing. You could probably all think of a regulation or a rule that either you worked on or that you experience in your practice or in your day-to-day jobs that you go, wow, this was well-intended, but really the way it's played out has been pretty bad. So if anyone wants to raise their hand and give me an example, or if you have a question for these guys, I know we got the mic going around. So any questions for the panel? Yeah, over here.
Terrific comments. Am I audible? Good. Okay, thanks. So with regard to the oncology treatments, has there been any sort of focus on honing in on most effective first-line treatments for various types of diseases, considering all the options for immunotherapy, so therapies in conjunction with chemo, maybe in blood cancers, so that you minimize the patient's journey and with the most effective treatment option on the outset? Could you comment on progress there? Sure.
So, not to speak for providers, but my take on that would be that when an oncology patient is sitting in front of the provider, that provider is always going to make the best choice for that patient. And they have to take a lot of things into account, not just the patient's disease, but also the patient's means, the patient's ability to come to and from their clinic for treatment, right? There are lots of social determinants of health that really play in determining what's the best treatment option for that patient. So I would tell you that, I'm a pharmacist. I work with providers. I have my whole career. What we see is that they're always putting the patient first and understanding the totality of the patient and what would be the best care for the patient at that time.
David, do you have a comment on that?
I think overall I would agree with that, except I would also say that I think that there's so much opportunity for physicians. There's only so much that we can know. So in some of those situations and some of those fine details of what insurances can cover which medication, or how is that going to work? What's the copay for this? There's too much out there for us to use without using technology to help streamline that. So you talk about, kind of specializing and tailoring your treatment, based on molecular genetics and stuff. And so I think there's a lot of opportunity for those things to move forward. Where we run into challenges is some of these technologies and stuff are not really reimbursable. It's not something that, yes, the technology may be there. It's something we could bring into a hospital to help facilitate making sure that we get this patient to the right place, the fastest way to do it, and streamline their treatment pathway. But if there's no reimbursement for that, how does a hospital who's operating on a 1% margin or actually losing money invest in $1 million tool that's going to help with this when they're trying to figure out how to pay for the lights for next month? In a priority list, they may say, yes, we want to do this, but it just doesn't work. So I think there's an opportunity, too, to try and figure out how do we help finance some of this technology so that it can be brought in, and so that it's not only at your large facilities, your Cleveland clinics, Mayo clinics, those places have enormous budgets, have the ability to do this. But your small rural community hospital who has a lot less resources, it's much more challenging for those patients to get back and forth, where you need some of this more, they just don't have a means to bring that in as well.
And I think Sloan's giving me the hook. Oh, we have one more question. I'm sorry.
I don't know if this is relevant or not. I'm just asking out there. 2.5 years ago, I was traveling overseas Europe, and I sustained a freak illness. I had to go into a hospital in Germany for a week. They had to operate on my leg. The bill was only about $5,500 because we're not covered under the healthcare system over there. So I guess if what I understand now, that's a fraction of what I would have to pay at the same thing happening in an American hospital. So I'm just wondering whether we can learn from our overseas persons how they do medical care cheaper than they do here. And, I'm just wondering why it costs so much more here to get treated than overseas. Thank you.
I think it's a very complex issue when you're talking about, we talk about our price transparency within, our United States market. I tell patients all the time that, when you look at the quality of care that we provide in the United States is phenomenal. Where else can you have a situation where we can actually go in and do heart surgery on a fetus while he's still in the mom's uterus and be able to do that? It's amazing what we can accomplish. Our problems relate around our delivery of care and our cost of care. And if you look at a buddy of mine just sent me his bill that he got. He's currently going through cancer treatment, and his first bill that he got for his initial treatment was over $100,000. And then that gets brought down. What the insurance has negotiated that price to is actually, $18,000. And then what he owes is $200. And just taking that off the surface, there is no way that you can have that discrepancy in numbers. And we talk about trying to weed out fraud. I think there's a tremendous amount of fraud in our process. A few years ago, I did a panel similar to this, and part of the discussion was that the reason why healthcare costs so much is because doctors order too many tests, and that it's the physician's fault as to why that happens. That was being presented by a payer, and I personally get offended by that. I don't think that that's true. It's not how I practice. Are there physicians out there that have committed fraud? You bet. But there's also, patients that commit fraud and milk the system and take advantage of the system. So I think the whole thing needs to be re-looked at in the way that we charge for the things. And I mean, it could honestly be a whole hour discussion to explain why is the cost of healthcare so expensive with everything that we do, and why is it truly a $25 aspirin? Do I have enough time to give my analogy? So part of the scenario, like guys, I'll kind of use the analogy. If you go to McDonald's, you have the dollar meal, and so this, if you go in and you go up and you say, I want cheeseburger, you give them the cheeseburger, they eat it, they sell you, I can't pay for it. And you are told that you run that McDonald's, you're told, if that person comes back in tomorrow, you still have to feed them. You have to give them their cheeseburger even though they're not going to pay for it. In the hospital, it's a very similar situation. We are obligated. I could care less what your insurance is or anything. I don't ask the question unless it becomes something relevant to where we're dispoing you and getting you to. But at the hospital setting, you are expected to have that patient treated, give them whatever treatment they need. If it's surgery, if it's a heart catheterization or whatever it is, you treat them, and then on the back end, you shore up all of the payment. So why does an aspirin cost $28? Because you're paying for all of the people that didn't pay for the aspirin, because if you're at McDonald's, your dollar meal now becomes a $2 meal to compensate for the people that aren't paying. So that's one small piece is the part that you are subsidizing part of the process that we don't pay. You're subsidizing the extra burden and all of the regulations that we have to go through of having enormous amounts of dollars spent to make sure that we're keeping up with all our metrics and do things that don't provide value, create additional cost that just doesn't need to be there.
And we're going to have to wrap it up there. Although we could talk for hours on this stuff, but why don't we give our experts a hand here?